Good morning, everybody. The topic of today's presentation is aneurysmal subarachnoid hemorrhage. An intracranial aneurysm is a cerebrovascular disorder in which there is weakness in the arterial wall leading to dilatation or ballooning, which may progressively enlarge and can eventually rupture. The rupture leads to aneurysmal subarachnoid hemorrhage. Incidence: worldwide incidence 2 to 16 per 1 lakh per year. Annual incidence of aneurysmal subarachnoid hemorrhage in India is estimated between 6 and 16 per 1 lakh people, resulting in roughly 76,500 to 2,04,100 new cases annually. It accounts for about 5% of all stroke. Age and distribution: mean adult age is 55 years. Overall, it is 1.2 times more common in women. Age-sex interaction: men higher at 25 to 45 years, women higher at 55 to 85 years. Men increased risk again after 85 years. It is rarer in children, that is, pediatric incidence is 0.182 per lakh population. Risk factors for aneurysmal formation: female sex, smoking, hypertension, coarctation of aorta, racial predisposition like Japanese, Finnish, hereditary syndromes like Ehlers-Danlos, pseudoxanthoma elasticum, polycystic kidney disease, FMD, familial aneurysm. Associated conditions are Ehlers-Danlos syndrome, vascular Ehlers-Danlos. Defect is in type 3 collagen, so hence there is fragile vessels. Neurofibromatosis type 1 and autosomal dominant polycystic kidney disease. In ADPKD, 8% will have saccular aneurysms. Classification of intracranial aneurysms by morphology: saccular, fusiform, dissecting; by pathogenesis: genetic, hemodynamic, infection, trauma, atherosclerosis, neoplasm, radiation, drug abuse, connective tissue disorder, vasculopathy; miscellaneous conditions like moyamoya disease. By size: less than 3 mm small, 3 to 6 mm small, 7 to 12 mm small to medium, 13 to 25 mm large, more than 25 mm giant. By location: internal carotid artery, cavernous, carotid cave, paraclinoid, ophthalmic, superior hypophyseal, posterior communicating, anterocoroidal, carotid bifurcation. Anterior cerebral artery, A1 segment, anterior communicating artery, A1 A2 segment, A2 and distal segment. Middle cerebral artery, M1 bifurcation, M2 and distal. Vertebral artery, pica. Basilar artery, trunk, fenestration, ICA, SCA, basilar apex. PCA, posterior cerebral artery, P1, P2 and distal. Saccular aneurysm, also called berry aneurysm, it is most common type, 90% of the cases. It is rounded, berry-like outpouching, arising from first and second order branches from the circle of Willis. It has a well-defined neck. It is responsible for the most aneurysmal subarachnoid hemorrhage morbidity and mortality. Here we can see many locations of saccular berry aneurysm of the circle of Willis. First one, anterior communicating artery. Second one, posterior communicating artery. Anterior communicating artery aneurysm 40%. Middle cerebral artery aneurysm 34%. Posterior communicating artery aneurysm 20%. Basilar tip aneurysm 8%. Second image, saccular and fusiform aneurysms are shown. Why do they form? Intracranial arteries are structurally unique. They lack the external elastic lamina. There is reduced elastic fiber in tunica media, and weaker arterial wall is present at the branching points. Image shows difference between intracranial and extracranial arteries, where intracranial arteries have lesser tunica media. They don't have external elastic lamina. They have lesser adventitia. Fusiform aneurysms. Definition: circumferential dilatation of the arterial segment. There is no discrete, well-defined neck. Common cause is atherosclerosis leading to tunica media damage and vessel wall stretching. Coming to special form, that is dolichectasia. Here there is marked elongation with tortuosity often in the posterior circulation. It can reach several centimeters in diameter. Clinical presentation is because of mass effect upon the cranial nerve and the brainstem. Rarely, ischemic stroke due to thrombosis or kinking of perforators can be the presentation, and rarely subarachnoid hemorrhage is also the presentation. In image, we can see first image computed tomography scan of brain showing enlarged basilar artery in the basal system and severe mass effect on the belly of the pons. Second image, digital subtraction angiography of the left vertebral artery showing dolichoectasia involving the left vertebral artery and entire basilar trunk. Third form, dissecting aneurysm. Mechanism is blood enters through the arterial wall tear and the wall splitting will happen. This leads to inward displacement of the arterial wall leading to stenosis, or it can lead to outward displacement of the arterial wall leading to aneurysm formation. Coming to difference between intracranial versus extracranial. Extracranial, there is intima media hematoma, that is narrowing, whereas in intracranial vessels, media adventitia hematoma, causing outward bulge, that is aneurysm. Clinical feature often presents with subarachnoid hemorrhage. It can be small and easily missed on angiography. Causes spontaneously can arise due to trauma, due to minor trauma like turning the neck, chiropractic manipulation, sneezing, sports. Underlying vasculopathy such as fibromuscular dysplasia is commonly present. Here we can see digital subtraction angiogram of the left vertebral artery, anteroposterior view first image, lateral view second image showing dissecting aneurysm just distal to the origin of the left posterior inferior cerebellar artery. Mycotic aneurysm, infectious aneurysm. It is rare but dangerous. It is caused by infection of the arterial wall, thereby causing weakening, thereby causing dilatation. This is classified as septic embolic mycotic aneurysm. It can be due to contiguous infection mycotic aneurysm. It can be cryptogenic mycotic aneurysm. It is more common in men and young to middle-aged adults. Common organisms are Streptococcus viridans most commonly. Fungi is Aspergillus and Candida. Blood cultures are negative in up to 13% of cases. Clinical features are often present with subarachnoid hemorrhage feature. Aneurysm is small and easily missed on angiography. It is imported as severe subarachnoid hemorrhage with no clear source. It can present as severe subarachnoid hemorrhage with no clear source. This is the difference between saccular, fusiform, dissecting and mycotic aneurysm. Saccular aneurysm has a well-defined neck. It is due to hemodynamic stress. It presents as subarachnoid hemorrhage. Fusiform aneurysm has no well-defined neck. It is due to atherosclerosis. They present with mass effect or ischemia. Dissecting aneurysms. These are variable. They may have a neck or not have a neck. They happen because of arterial wall tear. They present as subarachnoid hemorrhage. Mycotic aneurysms, they have variable presentation. They are caused due to infection. They present either as subarachnoid hemorrhage or intracranial hemorrhage. Rupture risk. Estimated annual rupture risk is 1 to 6.5%. The rupture risk is higher in case of women, older age group, posterior circulation, size more than 10 mm, symptomatic aneurysms. Aneurysm wall enhancement on gadolinium MRI suggests there is ongoing inflammation and hence indicate unstable or high risk of aneurysm. There is irregular morphology also which is suggestive of increased risk of rupture. Growth upon follow-up scan is also a strong indication for treatment because they have high rupture risk. Here we can see an aneurysm which showing gadolinium enhancement in the third image. This table shows us 5-year cumulative rupture risk based on the vessel involved. If it involves anterior circulation and posterior circulation, These are the size of the aneurysms and these are the percentage risk of rupture over a period of 5 years. Imaging modalities and diagnosis in aneurysmal subarachnoid hemorrhage. NCCT is the first line test. It is the investigation of choice in suspected subarachnoid hemorrhage. Sensitivity is 100% within 72 hours. Later, it decreases with time as the blood clears. If CT scan is negative but clinical suspicion is high, lumbar puncture has to be done. CT features are 1. Hyperdense blood in the subarachnoid space. It is a key finding. It appears as bright on non-contrast CT. Typical location are basilar system, sylvian fissure, interhemispheric fissure, cortical sulci. This is the earliest and most important sign. Here we can see CT scan showing hyperdense area in the subarachnoid space, particularly basal system and sylvian fissure. They can present also as intraventricular extension. Blood may enter the ventricles, lateral ventricle, third, fourth ventricle, suggesting severe subarachnoid hemorrhage and worse prognosis. They may also have hydrocephalus due to impaired CSF absorption. CT shows dilated ventricles, periventricular lucency. It's common early complication of subarachnoid hemorrhage. Later CTs after few days may show blood becomes isodense and hypodense, so very difficult to detect. So you should look for signs suggestive of hydrocephalus and infarct. Lumbar puncture is a gold standard test if CT is negative. CSF findings are increased RBC count and xanthochromia, that is which usually appears 2 hours after the bleed and it lasts for weeks. If CT with lumbar puncture is negative but suspicion persists, we should go for an angiography. Here image we can see xanthochromia. Difference between subarachnoid hemorrhage and a traumatic tap. In subarachnoid hemorrhage, RBC count is persistent across all the tubes. Xanthochromia is present after few hours. Clotting sample may not clot because the blood is older. Opening pressure is elevated. In case of traumatic tap, RBC count decreases in later tubes. Xanthochromia is absent. Clotting happens. Opening pressure will be normal. CT angiography, it's a non-invasive test, directly visualizes the aneurysm. It is useful in initial evaluation and treatment planning. If clear subarachnoid hemorrhage is present but CT angiography is negative, then we should do catheter angiography. In this image, we can see a CT angiography showing the middle cerebral artery aneurysm. B image, immediate postoperative CT confirming clipping position without complication, that is C and D. MRI findings, FLAIR has almost near equal sensitivity as NCCT brain. GRE sequences helps in detecting subacute and chronic bleed better than CT. Gadolinium enhancement, wall enhancement of gadolinium in gadolinium uh, contrast study suggests recent rupture. Here we can see CT and MRI brain different sequences over a period of years. MR angiography, non-contrast study, that is TOF MRI, is less invasive and good for screening, but it is less sensitive in slow flow aneurysms. Contrast enhanced MRI 3 Tesla has better visualization. Here we can say contrast enhanced MR angiograph and TOF MR angiograph showing a small inferiorly projecting aneurysm in the anterior communicating artery with maximal diameter of 2.6 into 3.1 millimeter. Conventional catheter angiography, gold standard for vascular anatomy. It is required if CT angiography is negative and it includes bilateral carotid and vertebral arteries. This is a six-vessel cerebral catheter angiogram of the bilateral servocervical trunk and costocervical trunk, ruling them out as the sources of subarachnoid hemorrhage. A and B images, bilateral vertebral artery injection, arterial phase, anteroposterior projection. C and D bilateral internal carotid artery injection, uh, arterial phase AP projection. E and F right internal carotid artery injection, venous phase AP and lateral projection. G and H, left internal carotid artery injection, venous phase, AP and lateral projection. I and J, right thyrocervical trunk injection, arterial phase, AP and lateral projection. K and L, left thyrocervical trunk injection, arterial phase, AP and lateral projection. Internal carotid artery angiograph illustrated the drainage of basal vein of Rosenthal, which does not drain into the vein of Galen due to discontinuous BVR. Here we can see 3D rotational angiography. It defines the aneurysm morphology, neck anatomy, and relation to the parent and daughter artery. It is essential for treatment planning. In the image, we can see a 2 mm middle cerebral artery aneurysm missed on distal subtraction angiogram in a 45-year-old man. A and D images DSA in project 4 projection fails to depict the aneurysm. E, e image demonstrating the aneurysm on a 3D rotational angiogram. Angiography negative subarachnoid hemorrhage. It is seen in 10 to 15%. Repeat imaging after 1 to 2 weeks is needed. Repeat study detects aneurysm up to 14% of cases. Classic presentation of ruptured aneurysm. Most intracranial aneurysms remain asymptomatic until rupture. They present with thunderclap headache, which is sudden onset, severe intensity, reaches maximum intensity within seconds to 1 hour, described as worst headache of my life. Associated symptoms are nausea, vomiting, neck stiffness, photophobia, loss of consciousness, focal neurological deficit, cranionopalsies. Typical presentation is sudden onset severe headache, frequently described as worst ever, associated with nausea, vomiting, neck pain, photophobia, loss of consciousness. Atypical features are confusion state, seizure, and associated head trauma. This table helps in suggesting the likely location of the lesion based on the finding. Mental status change seen in about one-fourth of the patient can be any location. Meningismus can be in any location. Third nerve palsy, 90% of patients with third nerve palsy due to aneurysm versus other causes of third nerve palsy have anisocoria, that is more than 2 millimeter difference. It is due to posterior communicating artery aneurysm. Sixth nerve palsy can be due to any aneurysm. Bilateral leg weakness and abulia suggestive of anterior communicating artery aneurysm. Nystagmus ataxia dizziness suggestive of posterior circulation. Hemiparesis with aphasia or neglect middle cerebral artery. Subhyaloid hemorrhage, that is Terson syndrome, seen in about 10% of patients with subarachnoid hemorrhage. It is associated with worse clinical grade on presentation and poorer prognosis. And location of aneurysm can be any vessel. Precipitating precipitating factors. Aneurysms are slightly more likely to rupture during physical exertion, Valsalva maneuver like defecation, micturition, heavy lifting. However, most ruptures occur during the daily routine activities. What is a sentinel headache? A sentinel headache is a sudden severe headache occurring days to weeks before major aneurysmal rupture, often called warning leak. It occurs in 10 to 43% of patients before the overt aneurysmal subarachnoid hemorrhage. Typically, it occurs as sudden severe thunderclap-like headache, but may be less dramatic than the rupture. Causes can be minor leak in a small aneurysm, subarachnoid hemorrhage, causing small subarachnoid hemorrhage, hemorrhage into the aneurysmal wall, or expansion or stretching of the aneurysm. Clinical importance increases the early rebleeding risk tenfold, often missed leads to catastrophic rupture. Ottawa subarachnoid hemorrhage rule. For alert patient more than 15 years of age with a new severe non-traumatic headache reaching maximum intensity within the 1 hour, patient requires additional investigation for subarachnoid hemorrhage if they meet any of the following criteria, like age more than 40, neck pain or stiffness, witnessed the loss of consciousness, onset during exertion, thunderclap headache, limited left flexion on examination. This flowchart shows us how to evaluate a patient suspected to have subarachnoid hemorrhage. Patient presents with acute onset severe headache. We have to apply Ottawa SAH rule and decide the next step of management. If the patient has presented after 6 hours or the patient has a new neurological deficit, then NCCT is indicated class 1. If this NCCT does not show any evidence of subarachnoid hemorrhage, then lumbar puncture has to be done, class 1. If lumbar puncture does not show xanthochromia, then further workup is up to the physician's discretion. If lumbar puncture showed signs of subarachnoid hemorrhage, the xanthochromia, then CT angiogram or digital subtraction angiogram is definitely indicated, class 1. If presentation is more than 6 hours or has a new neurological deficit and NCCT shows subarachnoid hemorrhage, then CT angiogram or DSA can be done directly without going for lumbar puncture, class 1. If patient comes within 6 hours and there is no new neurological deficit, then NCCT is recommended, but it is class 2A. If it is suggestive of subarachnoid hemorrhage, then CT angiogram or DSA has to be done, class 1. If it is negative for subarachnoid hemorrhage, then further workup is up to physician discretion. Clinical grading scales. These are used to assess the severity and predict the outcome. 1. Hunt and Hess scale. 2. World Federation of Neurological Surgeons scale. 3. Fisher scale. Higher the grade, worse the prognosis. Commonly used clinical grading scale for subarachnoid hemorrhage. Hunt and Hess scale, grade 0, asymptomatic. Grade 1, mild headache and mild nuchal rigidity, no neurological deficit. Grade 2, moderate to severe headache but no neurological deficit other than cranial palsy. Grade 3, drowsy, confused or has a mild focal deficit. Grade 4, stupor, moderate to severe hemiparesis or early decerebrate posturing. Grade 5, deep comatose or decerebrate posturing. World Federation of Neurological Surgeons scale, grade 0, GCS 15, motor deficits are absent. Grade 1, GCS 15, motor deficit absent. Grade 2, GCS 13 to 14, motor deficit absent. Grade 3, GCS 13 to 14, motor deficit are present. Grade 4, GCS 7 to 12, motor deficit may or may not be present. Grade 5, GCS 3 to 6, motor deficit may or may not be present. Fisher scale, grade 1, no bleed is detected. Grade 2, diffuse thin subarachnoid hemorrhage less than 1 mm, no clots. Grade 3, localized clot and or a thick subarachnoid hemorrhage more than 1 mm. Grade 4, intracerebral hemorrhage or intraventricular hemorrhage with or without subarachnoid hemorrhage. Cranial nerve presentations, unruptured or expanding. Aneurysmal location, nerve affected and clinical feature. Posterior communicating artery aneurysm, third cranial nerve is affected, presents with painful ophthalmoplegia with a dilated pupil. Anterior communicating artery aneurysm, optic chiasma is affected, bitemporal hemianopia is the clinical feature. Treatment of incidental unruptured intracranial aneurysms. Management must be individualized, considering estimated rupture risk, treatment-related risk, aneurysmal characteristics like size, location, and morphology. First-line measures for all patients are smoking cessation and strict blood pressure control. Risk stratification is by FACES score. FACES estimates 5-year absolute risk of rupture. P stands for population, H for hypertension, A for age, S for size, E for earlier subarachnoid hemorrhage from another aneurysm, S for site location. P for population, Japan +3, Finland +5, other population 0. Hypertension if present +1, age more than 70 +1, size of the aneurysm less than 7 mm 0, 7 to 9 mm +3, 10 to 20 mm +6, more than 20 mm +10. E. Earlier subarachnoid hemorrhage if S1, site ICA 0, MCA +2, ACA, ACOM, PCOM, posterior circulation +4. Depending upon the score, the risk of rupture is assessed. Management, initial assessment, we have to assess the neurological grade, Hunt and Hess scale and WFNS scale, and we have to find the source of hemorrhage. Poor neurological status may be because of acute hydrocephalus or intraparenchymal hematoma in 20% of the cases. Prevention of rebleeding, early critical phase. The highest risk of rebleeding exists in first 2 to 12 hours. 24 hours rebleed rate is 4 to 13%. Risk factors are poor admission grade, loss of consciousness, large aneurysms, SBP more than 160. Measures taken are early aneurysmal obliteration, definitive treatment, control of systolic BP less than 160 mm of Hg, prefer titrable IV agents like nicardipine, short-term antifibrinolytic agent less than 72 hours if unavoidable delay is present like tranexamic acid. Medical measures to prevent the rebleeding after aneurysmal subarachnoid hemorrhage. In patient with aneurysmal subarachnoid hemorrhage and unsecured aneurysm, frequent BP monitoring and BP control with short-acting medications is recommended to avoid severe hypotension, hypertension, and BP variability. In patient with aneurysmal subarachnoid hemorrhage who are receiving anticoagulation, emergency anticoagulation reversal with appropriate reversal agent should be performed to prevent rebleeding. In patients with aneurysmal subarachnoid hemorrhage, routine use of antifibrinolytic therapy is not useful to improve the functional outcome. Treatment modalities. There are two main strategies, open surgical clipping and endovascular treatment. The choice of surgery depends on aneurysmal size, neck configuration, location, circle of Willis anatomy, patient age, and surgical risk. The surgical foundation, 1808 to 1931, it shifted from simple artery ligation by direct exposure and muscle wrapping to reinforce the aneurysmal wall. 1936 to 1937, Dr. Walter Dandy performed the first definitive clip surgery. 1957 to 1960, the introduction of operating microscope and refined approaches like pterional craniotomy made surgery significantly safer. Open surgical treatment, that is clipping. The technique is craniotomy. Clip is placed across the aneurysmal neck. Multiple clips, if needed, are placed. Efficacy, complete occlusion in 90 to 95%, 1 year morbidity 9.8%, 1 year mortality 2.3%. Image shows schematic diagram of bifurcating aneurysm. First one is bifurcating aneurysm. Second one ruptured bifurcating aneurysm. Third one surgical clipping of bifurcating aneurysm. It is preferred in middle cerebral artery aneurysms, wide-necked MCA aneurysms, younger patient, and complex branch anatomy. Adequate neck exposure is the key determinant of the success. Higher surgical risk if posterior circulation, elderly patient, large or giant aneurysms. The rise of endovascular techniques, 1927 to 1964, imaging evolved from conventional angiograph to actual catheterization of intracranial vessels. 1974 to 1991, the major breakthrough occurred when Dr. Guglielmi introduced detachable platinum coils. This allowed to pack the aneurysm with wire to stop the blood flow without opening the skull. Evolution of endovascular treatment. Early foundation. 1927, Igas Moniz introduced a cerebral angiography foundation for all endovascular procedures. Initial endovascular attempts were 1964, Lusosenhov and Velasquez. First intracranial vessel catheterization was done. Balloon era, 1974, Fedor Serbenenko. Concept was balloon placed inside the aneurysm and hence occluded. The limitation was the balloon was rigid, hence there was risk of rupture. Modern era coil embolization, 1991, Guido Guglielmi developed Guglielmi detachable coils. The key advantages were it is soft, flexible, electrolytically detachable, retrievable and repositionable. Clinical transformation advantages over surgery are less invasive, reduced perioperative morbidity, shorter recovery time. Aneurysmal coiling, FDA approved in 1995, marked widespread adoption of coiling as a primary treatment modality. Minimally invasive technique, it is performed via endovascular approach. Core principle, fill aneurysmal sac with coils, exclude it from circulation. Mechanism of action, dense coil packing induces thrombosis, clot formation inside the aneurysm. Primary goal, achieve stable occlusion and prevent rupture or rebleeding. Ideal aneurysm characteristic for simple coiling, narrow neck, favorable dome to neck ratio. Limitations, less effective in wider neck or complex aneurysms. Risk of coil instability or recurrence. Adjunct techniques for complicated cases, balloon assisted coiling, stent assisted coiling, flow diverter devices. A 33-year-old patient with Hunt and Hess grade 3 subarachnoid hemorrhage. CT shows an extensive subarachnoid hemorrhage, Fisher 3 grade. Second image, three-dimensional CT angiogram demonstrates a saccular aneurysm arising from the left internal carotid artery terminus. C image, distal subtraction angiography, anteroposterior view prior to the endovascular treatment showing aneurysm measuring 4.7 mm in height, 3.2 mm in width. D image, after the treatment, the aneurysm was completely obliterated using platinum coils. Patient with the incidental basilar tip aneurysm. Aneurysm grew over a conservative follow-up period at 10 to 18 mm in the largest dimension, and a decision was made to proceed with the stent-assisted coil embolization. Aneurysm incorporates both posterior cerebral arteries. B image, a 4 into 30 mm neuroform stent was placed from the right posterior cerebral artery down to the mid-basilar artery over an exchange wire. Aneurysm was subsequently packed and platinum coil from two microcatheters placed in the left and right sides. C image, post-embolization angiogram showing complete obliteration of the aneurysm with preservation of the blood flow to the posterior cerebral arteries. Balloon-assisted coiling indication used for wide neck complex aneurysms where simple coiling is inadequate. Problem addressed prevents coil prolapse and improves coil stability in unfavorable anatomy. First described 1997. Basic technique, temporary inflation of non-detachable balloon across aneurysm neck during the coil deployment. Enables dense coil packing. Schematic diagram of double lumen balloon and its use in the treatment of bifurcation aneurysm. A. Double lumen balloon. B. Bifurcation aneurysm treated with balloon assisted coiling. Stent assisted coiling core concept. A permanent intravascular stent is placed across the aneurysmal neck, provides a stable scaffold for the coil placement, overcomes the limitation of temporary balloon support. Mechanism and advantage. It provides permanent neck support, prevents coil prolapse into parent vessels, enables treatment of wide neck aneurysms. Compared to balloon assisted coiling, more durable support, requires long-term antiplatelet therapy. Complications, thromboembolic events most important, procedure-related rupture, need for dual antiplatelet therapy also. Evidence, better occlusion rates versus conventional coiling, higher packing density, shows safety and improved efficacy in complex aneurysms. Flow diverting stents, basic principle, it works by altering intra-aneurysmal hemodynamics. Two clinical actions, redirect blood flow away from aneurysm, causes stasis and thrombosis. Provides scaffold for the neo-endothelialization, vessel wall healing. Results, functional cure by reconstructing the parent artery. It leads to gradual aneurysm thrombosis, progressive collapse of aneurysmal sac, formation of new endothelial lining. Schematic diagram showing treatment of side wall aneurysm. Side wall aneurysm first image. Endovascular treatment using conventional stent and coiling. C image endovascular treatment using flow diverter stent without coiling. Time course. There is delayed effect unlike clipping or coiling. Takes 6 months to 12 months for complete thrombosis and vessel healing. Efficacy. Occlusion rates more than 90% long-term occlusion. Compared to coiling, lower recanalization 20% in coiling, lower retreatment 10%. Indications initially for used for giant aneurysms, fusiform aneurysms, difficult or unclippable aneurysms. Now also used for wide neck aneurysms, recanalized aneurysms. Limitations. It is not ideal for acute ruptured aneurysms. Since there is no immediate protection and it requires dual antiplatelet therapy. Major new devices, intrasaccular flow disruptor, example woven endobridge. It is placed inside aneurysmal sac. Mechanism is disruption of blood flow promoting the thrombosis. Advantage, there is no need of long-term antiplatelets. It is ideal for bifurcating aneurysms. Neck bridging devices. P-conus device acts as scaffold at aneurysmal neck, used with coils for wide neck bifurcation aneurysms. Pulse rider, designed specifically for bifurcation aneurysms, provides targeted neck support. Use of P-conus device in treatment of bifurcation aneurysm. P-conus device first image. Bifurcation aneurysm treated with P-conus device and detachable coil. Use of pulse rider device in the treatment of bifurcation aneurysm. First A-B pulse rider device. C bifurcation aneurysm treated with pulse rider device and detachable coil. Endovascular clip system. Use of E-clip device in the treatment of bifurcation aneurysm. E-clip device first two images. C image bifurcation aneurysm treated with E-clip device and detachable coil. Wrapping technique. Basic concept. The aneurysm is wrapped with biological or synthetic material aimed to reinforce the weak aneurysmal wall, promote fibrosis and stabilization. It doesn't exclude aneurysm for the circulation. Indications. It is the last resort technique. It is used when clipping is not feasible, endovascular therapy is not possible. But it is particularly useful in friable aneurysmal walls, dissecting aneurysms, situations where direct manipulation is riskier. Materials used are autogenous tissue like muscle, dura, synthetic materials like cotton, cellulose, fabric. Complications. Hydrocephalus, rebleeding of subarachnoid hemorrhage, vasospasm, neurological deficits, hypothalamic dysfunction leading to myocardial ischemia or labile detrimental BP, hyponatremia, aspiration pneumonia and other complications of critical care, left ventricular systolic dysfunction. Delayed cerebral ischemia, it occurs 3 to 20 days, peaks at 7 to 10 days. So it is symptomatic in 30% cases. It is a major cause of morbidity mortality. Pathophysiology, oxyhemoglobin breakdown, endothelin 1 and free radicals will cause prolonged smooth muscle contraction, hence ischemia. Medical management of vasospasm, nimodipine cornerstone therapy. Start immediately, continue up till 21 days, reduce the delayed cerebral ischemia and it is neuroprotective. Hemodynamic management, avoid hypotension and hypovolemia. Endovascular treatment of vasospasm, used if medical therapy fails. 1. Balloon angioplasty for proximal severe spasm, longer lasting effect. Intraarterial vasodilators for the distal spasm, example papaverine, verapamil, fasudil. It is not first line due to procedural risk. Management of hydrocephalus associated with aneurysmal subarachnoid hemorrhage. In patient with aneurysmal subarachnoid hemorrhage and acute symptomatic hydrocephalus, urgent CSF diversion, EVD and or lumbar drainage should be performed to improve neurological outcome. Management of seizure associated with aneurysmal subarachnoid hemorrhage. In patient with aneurysmal subarachnoid hemorrhage and either fluctuating neurological examination, depressed mental status, ruptured MC aneurysm, high grade of SH, ICH, hydrocephalus, or cortical infarction, EEG monitoring is reasonable to detect the seizures. In patient with aneurysmal subarachnoid hemorrhage and a high seizure risk features, that is ruptured MC aneurysm, high grade SH, ICH, hydrocephalus, cortical infarction, the use of prophylactic anti-seizure medication may be reasonable to prevent the seizures. In patient with aneurysmal subarachnoid hemorrhage without high risk features like ruptured MC aneurysms, high grade SH, ICH, hydrocephalus, cortical infarction, prophylactic treatment with anti-seizure medication is not beneficial. Differential diagnosis for subarachnoid hemorrhage, sentinel headache, cerebral venous thrombosis, cervical artery dissection, spontaneous intracranial hypotension, pituitary apoplexy, retroclival hematoma, ischemic stroke, acute hypertensive crisis, reversible cerebral vasoconstriction syndrome, colloid cyst of the third ventricle, acute complicated sinusitis, primary thunderclap headache, infections, acute myocardial infarction, anaplastic oligodendroglioma, aqueductal stenosis, pheochromocytoma.